Hello and welcome to Learning Thursdays. My name is Bridget Hartman DeCenzo and I'm today's host for Learning Thursdays. Today's presentation is Medication-Assisted Treatment, How It Works and Its Effectiveness. And our presenter is Dr. Charles Morgan, OASAS Medical Director. If you have any questions about Learning Thursdays, please send an email to learningthurs@oasas.ny.gov. And if you're interested in earning credentialing hours, you should know that Learning Thursdays presentations are free and approved for 1.5 credentialing hours. After registering for each presentation, you will be sent a link for the broadcast, PowerPoint, associated handouts, and a credentialing certificate. Type or write in your name in the space provided on the certificate, and please be sure to send in the sign-in sheet to the address as indicated on the form. Your sign-in sheet must be on file for your certificate to be recognized by OASAS's credentialing unit. I'd like to draw your attention to the evaluation link shown on this slide. To help us better meet your training needs, please complete this very brief evaluation. The web link can also be found in the email that accompanied this presentation. And now we will begin.
Thank you, Bridget. I'm Dr. Charles Morgan. I am the OASAS Acting Medical Director, as Bridget said, and we're going to be talking today about medication-supported recovery, which many of you have known as medication-assisted treatment. Here in OASAS, we like to use the word medication-supported recovery because we're talking about recovery here from the disease of addiction. I'd also like to invite you to check the Combat Heroin site. We'll have more information on that later in the presentation, and links, phone numbers, and things for you. There are many resources on that site that can be useful to you as organizations and as individuals who are maybe affected by the heroin epidemic that we've experienced in the country from now on. We're very glad for that site. The site focuses on two things. It focuses on the devastation that heroin causes people, and it focuses on the hope for recovery. And we think both of those are really important and vital. So we're going to get started with the presentation right now because we've got a lot to cover. I'm glad to be here. This is an important topic. It's one that's very close to my heart. And this is an ASAM policy statement that was issued some time ago on alcoholism. We're not talking about alcoholism today. We're talking about addiction. But the disease is a chronic disease. And when we talk about chronic diseases, we don't use the word cure for chronic diseases. There's really no cure for many diseases, and we don't expect them to be cured. We're looking for cures all the time. But with this disease, just because it can't be cured doesn't mean that it can't be treated. And we're going to look at some of the ways that happens today. And just because it can't be cured doesn't mean that our patients or their families are doing anything wrong. So what we can get into, though, is we can get into what recovery is. And a state of recovery is possible from this illness, just as it is from many illnesses. If a person has had a heart attack, a person can return to functioning. If a person has diabetes, a person can still, when they're in recovery from that illness, participate in life. And so can our patients who are in states of recovery. In fact, I'm going to let you read this for yourself right now, these statements. But what you'll see if you read this statement is that when a person is in recovery from the disease of addiction, that person has return of function in many different parts of their lives, and they achieve a level of comfort. When a person is in remission, a person generally gets into remission and stops using drugs before they get into the state of recovery. But the remission is what is necessary for the state of recovery to occur. Later in the presentation, we will look at what abstinence means when we talk about medication-assisted treatment. But we'll get into that a little bit later. Here are some indicators that a person is in recovery, and what you'll notice is that recovery involves improvement in almost every area of the patient's life. And you'll notice that last one down there, a willingness to share about the recovering state. Now, sometimes in some people's lives, there are reasons why a person might choose not to share about their recovering state, which might have to do with protecting their job or some other consequence that could happen. So that one down there is not always something that you'll see in every recovering person. When we look at what's going on, we know a great deal about this illness today. There's a lot we don't know still, but there's a lot that we do know. And when we talk about the disease of addiction, we are talking about a brain disease. We're not talking about a disease concept or anything like that. We're talking about a disease of the brain. In this slide, I'm not going to go into all of these different areas, but many of you know these names like ventral tegmental area, nucleus accumbens, prefrontal cortex, cerebral cortex. You know those names, amygdala. This is where we think the disease resides. We think it mainly resides in the midbrain, the ventral tegmental area, and we think that there is cortical dysfunction as well. So what this slide says is important. It's a primary disease. It means it's not caused by something else. It's its own entity. We don't have to explain why somebody becomes an addict. All we have to know is that it's a primary illness. It probably has a multifactorial cause in some people. Sometimes it's genetic, sometimes it's related to a history of trauma, but we know that it's a disease in its own right, and that it's characterized by motivation, memory, and related circuitry dysfunction. Here's another way to talk about the illness. When we talk about it in terms of the criteria from the American Society of Addiction Medicine, for instance, we know that this is a biopsychosocial spiritual illness, and there are dysfunctions in all the areas. You can see the brain represents the biological dysfunction, and it is a true biological defect of the brain. Those smiley faces represent the social dysfunction, or the emotional, psychological dysfunction. The people at the bottom of the slide represent the social dysfunction, and then this other figure there represents the spiritual illness. And likewise, when we talk about recovery from this illness, we're talking about recovery in the same way. We're talking about it in terms of a biopsychosocial spiritual recovery. What we know about this in terms of the disease itself is that the disease is biopsychosocial spiritual, like I said, it affects the entire person. We also know that the total cause is unknown. Now, interestingly enough, while we like to do research and try to find out the cause, and NIDA has done a lot of that research, and they're to be commended for all of the good work that they've done. SAMHSA has been involved in that. They're to be commended for all of the good work that they've done. We still don't know what the total cause is, but we do know that we can treat the individual and have successful outcomes even when we don't know what the total cause is. We know that the illness is at least partly chemical. That means that in order to have it manifest, there has to be the addition of some kind of a disease. And in opioid dependency, what we're talking about is the addition of opioids. The other important part of that, though, is down at the bottom of the slide, you can see that there is a cross addiction. And when we talk about getting into recovery from the disease of opioids, we need to talk about not only abstinence from opioids, but abstinence from other things that may be intoxicants. And I want to make it absolutely clear right now that when I use the term intoxicants, I am not talking about the medications that we use to treat the disease. I am not talking about methadone, buprenorphine, or naltrexone. All right. Treatment, again, involves all of those same areas that we talked about before. And here's a slide from my predecessor, Dr. Steve Kipnis, and I want to give him credit for that. The medications are important because what they do is they treat that biological portion of the illness that occurs in the brain. But there's a whole bunch of other stuff that needs to occur. And this slide says 12 steps are for the soul. That was Dr. Kipnis's terminology, and it's Very good. We know, however, that there are many people who get sober in many different ways. George Valen, who's a professor at Harvard Medical School and who's published books, articles, told us that about 40% of people who stay sober in the 12-step programs, in the program of Alcoholics Anonymous, for instance. But the other 60% who are staying sober are doing things that are similar. They have similar effects to those kinds of things that people experience in the 12-step programs. All of them have in common that they're having spiritual experiences. Robertson out at the University of Michigan did a study on that in the past, and what she showed was that of those people who stay sober, the things that they have in common are they have spiritual experiences and they have a sense of purpose. So let's go on with the slides now. And can medications support recovery? Yes, they can. Can medications interfere with recovery? Yes, they can. And that's the point of this entire presentation. When we give medications to our patients, what we want to do is we want to enhance their recovery, not interfere with their recovery. So that's why the way these medications are prescribed is ever so important. Well, what can medications help with? This slide, I apologize for the unclarity of it. It's a photograph, actually, that a colleague of mine sent to me that he uses in his presentation. So that's why it's a little bit blurry. And he's got checked off there, what can medications do? And you can see that what he's checked off is that they help with acute withdrawal, they help with post-acute withdrawal symptoms, they help with cravings and psychiatric problems. Down further are the other things that we do in treatment affect. I think, though, that I would add to the check marks under medications, I would add that unmanageability of life is also aided by the medications, because once you give a patient the medications we're going to be talking about today, almost immediately the use of opioids can cease. And while the patient has not experienced the psychosocial spiritual recovery yet, if a patient can stop using drugs, unmanageability decreases. You don't have to go to the corner and cop dope. You don't have to be a sex worker to support your habit. You don't have to steal from the people that you love the most once you can stop. So I think there are a couple of other things that I would check off under what medications can help. And you can look and you can see what you think might be able to be checked off there as well. Well, what medications are approved for the use of opioid therapy? Here's a list of them right here. Methadone is the first one. It's the old tried and true thing. It's still the gold standard. When you talk to many professionals, that's what people will say. Buprenorphine has been approved since, Data 2000 changed that. We'll talk about that in a few minutes. These are some trade names for buprenorphine. Bunavail we don't have on the market yet. Suboxone is a strip. Right now, in some other countries, I think you can buy Suboxone as a pill, but not in the U.S. Zubsolv is a pill, and Bunavail will be a film that goes on your cheek. And then there's generic buprenorphine now, which usually is abbreviated BUP/NAL. Naltrexone has been around since, it was actually, we'll talk about this later, but synthesized, I think, President Nixon was the one who was interested in that. We just got Vivitrol on the market now. Many of you have heard about that. Here's pictures of these things. In the upper left-hand corner, you can see what methadone often looks like when it's dispensed in a methadone clinic. It gets put in bottles like that, and patients can bring those bottles home after they achieve a certain level of recovery, which isn't just abstinence from the chemical. It involves some biopsychosocial stability. Those caps usually seal on the bottles, and You can see the label sticking out on the bottom bottle there. That's the prescription. It's got the patient's name. It's got the medication in it, and it's sealed up. The green liquid is what methadone might look like when it's dispensed in a clinic. Suboxone comes in those kinds of foils that you see in the middle picture there, and inside that foil is a strip that looks a lot like a Listerine strip, except it's orange. Beneath that is Zubsolv, and on the far right is what Vivitrol looks like. It comes in a kit like that where we mix up the Vivitrol, and it comes with its own syringe and its own needles. Well, here are some things that medications can do. They reduce criminal activity, they reduce risky sexual activity, and they reduce disease transmission. So what do the medications do? Well, they do a lot of things that we have talked about in terms of harm reduction. And those things are very, very, very important. I can't think of why someone would not want to reduce harm, to tell you the truth. We'll go into later in the presentation how they actually treat the illness as well. But these are some of the things that actually we think of when we think of harm reduction. And it's well known that when you put people on methadone, there have been many studies, we'll look at one of them in a minute, that have shown that people don't have to go out and do the same kinds of things that they needed to do before they started the methadone, because they don't have to steal anymore. They don't have to go and divert medications. They don't have to write themselves prescriptions in the doctor's office or steal prescription blanks. They don't have to, because of the change that occurs, a lot of people talk about addiction in terms of Dr. Jekyll, Mr. or Mrs. Hyde. And when a person is using drugs, many times their personality changes and they do things that they would never do otherwise. And you'll hear families say, you know what, when he's not using, he's the sweetest person in the world. But once he uses, you can't do anything with him anymore. And so we know that domestic violence and all kinds of things occur and increase when people are using drugs. And the medications can reduce all of those different things. They reduce risky sexual activity. I've taken care of people in my practice who have been amazing people who have to be involved in the sex industry in order to support their habit. That's not the kind of thing that they would do if they didn't use drugs. And so when you stop the drug use, that person who's been bound to doing things that she or he doesn't even want to do can suddenly stop doing them. Provides relief to the person, provides relief to society as well. And then look at all the diseases that we know are increased by the use of IV drug use. We see probably in some populations, we know that there are about 85% of our people who are opioid dependent and IV drug users who are hepatitis C positive. We know that HIV transmission is reduced because people aren't sharing needles anymore, they're not doing risky sexual activities, STDs are reduced, hepatitis B is reduced. And when people do get those illnesses and they are on medication-supported treatment, when they're on medication-assisted recovery, if people do have hepatitis C, their chances of being able to follow through with treatment, follow through with getting genotyped for their hepatitis C are much increased. The chances for being able to stay on your HIV medications and not to develop resistant virus are increased when you go on medications to stop your opioid use. So it's not just that the disease transmission is reduced, but the outcomes for people who have those diseases are improved as well. These are some other things that medications can do. They can reduce cravings. Can you imagine what it would be like to feel not just like you wanted to use something, but like you needed to use it? You couldn't exist if you didn't use it. If the only way that you knew to cope with something was to use it, and you were driven to use it, and yet that was the thing you didn't want to do. Our patients will say, like, it's like there's two people inside of me. There's one that doesn't want to use. I don't want to leave treatment, but I don't know how I can stay. The other thing that medications can do, they can enhance engagement in treatment. That's well known, and we'll see a slide about that in a couple of minutes as well. But part of it's because the medications, when you take these kinds of medications, when you take methadone or you take buprenorphine, you are physically dependent. You go into withdrawal when you're not taking it. And so that does tend to keep people coming back. But we know that medication, that engagement in recovery is even enhanced with Vivitrol. And Vivitrol doesn't cause any physical dependence at all. So it's more than just a physical dependence that keeps the patients involved. And they certainly reduce the use of intoxicants. The other thing that I think is extremely important and can't be minimized is that in order to get methadone, in order to get buprenorphine, you have to go to a provider who has special training in giving those medications and who has some expertise in addiction. And so when you're on either one of those medications, you have more contact with professional caregivers. And so my experience in working with patients in methadone clinics and with patients who are taking buprenorphine and with patients who are taking Vivitrol or Naltrexone is that they come to me for the long haul. And so I get to not only see them during their detoxification period or the rehabilitation period, I get to see them in that first year of sobriety when they're learning to live without drugs. I get to see them in that second year of sobriety when the AA people would say, you're learning to live with yourself. I get to see them in that third year of sobriety if they're still on the medications when they're learning to live with other people. And sometimes what happens during that period of time is that initially the patient gets better, but later on in the second or the third year of treatment, the PTSD starts to surface, or the other complications that they have experienced in their illness, in their addiction, start to come forth, and we get to work on those things. So that increased contact with professional caregivers is extremely important. And the medication-assisted treatment, I think, is one place that we see that more than almost any other kind of treatment. Well, here's the thing that I promised to talk about with you. I'm going to explain a little bit about this to you first, about what the study was, and then we'll come back to the slide in a minute. This was a study that was done in the forensic population and people who were incarcerated. And there were three groups of patients the people were divided up into three groups of patients. And one group got a recommendation to go to a methadone program. The second group that we'll look at, whose bars will be in orange when you see the slide. The first group, the bars are in blue that I just talked about. The second group, the bars are going to be in orange. That group actually got a referral to a methadone program. And the third group, whose bars are going to be in purple, got started on methadone before they left the where they were incarcerated and got transitioned right to a methadone maintenance program. And let's take a look at the slide and see what the three groups, what was different about those three groups. Okay, so the first set of bars over on the left is the number of people, the percent of patients who were still involved in treatment at 1 year. It's that retention that I talked about before. And you can see that that blue bar group there is 0. None of the patients who just got told to go to a methadone program ended up being still in treatment. On the other hand, that purple bar, which is a little bit taller there, you can see that the retention after a year, when the patient was actually started on methadone before they left the jail or the prison, there were significant 36.7% is what that says. The second group of bar graphs is the number of opioid positive screens. And what you see there is that the people who got started on methadone before they left the prison had far less involvement with opioids. Now, interestingly enough, when you look at cocaine, and that's that cross addiction that I talked about before, because you could be off opioids, and that would be great. If you were off opioids, it would be a relief. But if you're still taking cocaine and you're having to do the things that you have to do to be on cocaine, you could still have some dysfunction in your life. All right. Now, with opioid, I want to talk a little bit about the power of opioid dependence here. This is something that isn't, I don't think it's published. It's my own thinking here. So in the interest of full disclosure, nothing that I'm going to say is inaccurate. I just think this explains why opioid dependence is a little bit different. We talk a lot about dopamine, and I don't want to minimize the importance of dopamine. But we used to talk a lot about endorphins as well. And we know that the opioid system is involved with endorphins. For every single chemical that has an effect in the brain, there is a naturally occurring thing that our bodies make that have effects in the brain. In the case of opioids, it's endorphins. In the case of other drugs, alcohol, for instance, it may be glutamate and gamma-aminobutyric acid. So every one of these, some of them have MDMA receptors. Every one of the things that can have an effect in our body, even with other medications, has a place in our body where a naturally occurring thing works. I could give you an example of something that doesn't have an effect in the body, and it's cellulose. That's what's in Metamucil. And Metamucil, cellulose, has no place within our bodies that it can act. And so when we take cellulose, which is what's in Metamucil, it adds bulk to our stool, and it improves bowel movements and constipation because there's no place for it to go. It's not even absorbed into the body. So these naturally occurring endorphins are what the opioids work on. They work on the endorphin receptors. And what do endorphins do? Well, endorphins, I believe, are incredibly important chemicals in our development as the human race. They have a great deal of importance evolutionarily, if you look at that. And let me explain what I mean by that. A lot of people think of endorphins as, oh, you know what? They make you feel pleasure. They make you feel nice. Well, they do more than that. Endorphins are produced, they're naturally occurring pain relievers. So you've experienced that when you stub your toe. When you stub your toe, after about a second, it starts hurting a lot. And you probably have something that you say when you stub your toe. I don't know what it is, but you might say a few words. Besides ouch, I don't know. Anyway, when you go through that, however, what you notice is that if you pay attention, the next time that happens, what you'll notice is that the pain goes away. And that's because you get a surge of endorphins that are released, and they're naturally occurring pain relievers. Now, there's some other things that happen with dating phenomena in the spinal cord and things. It's not quite as simple as I'm making it sound, but that is one of the things that they do. Now, the second place that they're released, and there may be some endocannabinoids released in this case as well, but we know endorphins are also released, is when you exercise. When you're on the treadmill in the gym, or when you're running and you've gone about 15 minutes, you want to quit, if you're like me. But if you go 20 minutes, what happens is you don't want to stop running. You feel good, and you get that second wind, and you get what's called the runner's high. It feels really good, and you feel like you could run forever. The third place that endorphins are released naturally in the brain are when we have a climax, a sexual climax, when we have an orgasm. And it's the feeling good time, or whatever you want to call it, that peaceful, wonderful feeling that people get when they have an intimate relationship with another person. Think about that in terms of before we had civilization the way we have it now. Think of that particular thing if we're in the wild and we have to catch our food and we're fighting to prevail and to survive. When you look at evolution, what needs to happen is that genome that gets reproduced is the one that survives, and that genome is the one whose characteristics will be imparted to the next generation. So, if you've got an organism, a human being, that when they're chasing their food and they jump over the stump and they stub their toe, they have a naturally occurring pain reliever that means that they can go on and continue to chase that beast, or if they're being chased by the beast, to run away from it so that they don't become the beast's food. Either way, that's going to be a naturally advantageous thing to have. The second thing is when you're trying to catch that beast, if you can have a chemical that makes it so that you can run even longer, that's going to be a very important thing too. And if you have something that makes you want to reproduce, that makes that feel good to you, then that organism is going to go forth and multiply, if you want to frame it in that terms, or survival of the fittest. You can frame it in any terms you want, but those are really, really important chemicals. Now, the disorder in our people who are opioid dependents is in that system, and I am postulating to you that if you have that kind of a disorder which is directly related to your survival and you don't make enough of those endorphins, or you've done something to inhibit those endorphins, and it goes right into your basic instinct as a human being to survive, and you don't make enough of those things, then if there's another place for you to get them, you're going to go for that. It's not going to be a choice that you have. It's going to be an instinct that you have to go get those things. And so if you're in withdrawal in a treatment center and it's not being treated, you're going to leave. These medications that we're talking about combat that withdrawal and make it possible for patients to engage in treatment, like the study showed earlier. I think after a while, maybe the engagement in the treatment is what keeps people coming back. I had a person who told me the other day, you know what, I didn't want Suboxone when I first got sober, but I had to take it. But you know what it did for me? If I hadn't kept coming back to you, Dr. Morgan, the only reason I came back to you is because I needed to get that Suboxone. But in coming back to you, I also got involved in my 12-step program. I got involved in the groups that we had here. And now what's happened to me is I want to be sober. I didn't know I wanted to be sober when I first came to you. Now I like it. I'm going to keep going to those meetings and things. His motivation was external when he first came around, and his motivation has become internal now. It was a powerful statement for me to hear that from my patient. So how do these things work? Well, there are receptors and there are ligands. In the case of endorphins, endorphin is the ligand. It's the naturally occurring thing that occurs in the body, and it fits onto specific places in the brain, and when it fits onto those specific places in the brain, has the effects that we just talked about. So, in order for the ligand to work on that receptor, it must fit exactly into the receptor. It's like a key that has to fit into a lock. And not only does it have to fit into the lock, in order for it to have an effect, it's got to turn the lock. It's got to change the receptor. And in many cases, what happens is ions flow differently through the brain tissue, sodium ions, calcium ions, and things like that. And that's how these things work. So they're naturally occurring things with receptors and ligands. Well, the drugs that we use are ligands as well. Methadone, buprenorphine, and naltrexone are ligands of a sort. They all fit into the receptor, but not all of them do the same thing. Naltrexone is what we call an antagonist, the middle thing on that slide that we're looking at right now. And what naltrexone does is it fits onto the receptor and blocks it, but it does not turn the key. It's a key that fits into the lock and doesn't turn the lock. So it blocks the receptor, but it doesn't have an effect on that receptor. The top one is what's called an agonist. And what an agonist does, methadone is an example of an agonist. What methadone does, it fits into the receptor just like naltrexone, but it turns the lock. And the more you give of methadone, the more it turns the lock. So the more of an effect it has on that opioid or endorphin receptor. Buprenorphine is an example of the bottom one. And what buprenorphine has, we'll look at this in a few minutes, it's what's called a partial agonist because it fits on the receptor, but it doesn't turn it all the way. It only turns it so far. And once it turns it that far, it's not going to turn it anymore. So it has what we call a ceiling effect, C-E-I-L-I-N-G, ceiling. All right, so let's take a look at methadone, which is the full agonist. Methadone has more affinity for the receptor than other opioids that patients take. For instance, the prescription opioids that we're so concerned about now that our youth are getting out of their people's medicine cabinets, which is why on our Combat Heroin website we have the medicine cabinet inventory that you can get and you can use to keep track of what's in your medicine cabinet and see whether it's being used by somebody else. And we also have instructions there for how to dispose of the opioids that you no longer need. We advise getting them out of your medicine cabinet, as a matter of fact. But methadone, because affinity means basically stickiness to the receptor. So methadone is stickier to the receptor than either those prescribed opioids or heroin. So methadone will push the other opioids off the receptor and push heroin off the receptor. That's really important because if a person takes opioids on top of methadone, if a person takes heroin or opioids on top of methadone, there's no place for those opioids to go. And so the patient doesn't experience what they would normally experience. They don't experience anything from the opioids that they take. And so a patient will come back to you when they're blocked with methadone and they'll say to you, you know what, doc, if they feel safe with you, and hopefully they do, you know what, doc, I took some heroin. I know you told me not to, but I took some heroin and I didn't even feel it. You can say, oh, yeah, well, that's because the methadone is blocking your receptors, like we said. And so then you say to the patient, what do you think you'll do about that? And the patient says, well, I'm not going to waste my money on heroin anymore. Okay, then, of course, you've got to treat the cross addiction so that they don't use other things, because the methadone isn't going to block anything to do with cocaine or alcohol or anything like that. An advantage of methadone is that it's only given in clinics. That can be a disadvantage as well because it limits the number of places where you can get methadone. And if you're in a rural area, it can be hard to get to those clinics. But it can also be an advantage because if you've got to go to the clinic every day to get your dose of methadone until you get stable, that can be an advantage that gives you that daily contact with a professional who can say, hey, Charlie, how you doing today? Any problems? We know a lot about methadone. It's been used since the 1960s. It's tried and true, and it's still the gold standard. Well, methadone is probably the most highly regulated medication in this country. It is regulated by federal regulations. It's regulated by our state, and it's regulated by certain institutional regulations as well. The federal regulations specify that it can be given only in methadone clinics. The federal regulations specify how methadone can be induced. It can be induced in no more than an initial dose of 30 milligrams, and later on in the day, after a period of time, you could give an additional 10 milligrams. But you can never give more than 40 milligrams on the first day. So it's my purpose in telling you that is not to make you experts in giving methadone. That's a whole nother thing that doctors know how to do, but it's to tell you how closely regulated this is. there are take-home policies that exist with methadone. That means that in order to take any methadone out of the clinic, you have to achieve a certain number of months of urine toxicologies that are negative for everything except methadone. Now, urine toxicology for a patient on methadone that was normal or that wasn't alarming would include methadone, because if the patient doesn't have methadone in their drug screen, it means that they're not taking it. So a normal drug screen for a person on methadone would include methadone. So in order to achieve getting take-homes from a clinic, which means you take a dose of methadone out with you on a day that the clinic would normally be open, you'd have to have a number of months without having taken any other drugs at all, taking your methadone as prescribed. You'd have to have no new legal involvement. You'd have to have a safe place to take the methadone into. You can't be in an unsafe place with other users. You have to have a certain level of biopsychosocial stability. You have to achieve that. And so methadone is really a wonderful, wonderful modality of treatment when you look at it that way, because the patient gets to recover before they're taking risky drugs out of the clinic. And as the patient stays sober longer and gets into more and more recovery, they may end up having to come to the clinic only once every 1 or 2 weeks. So that's a good thing. There's strict criteria for being eligible to be on a methadone clinic. You have to have a year of opioid use. You can't have used for just a month. And you have to have a current physiologic dependence, which means you have to currently be dependent on opioids. Now, there are exceptions to that. One is that if you're pregnant, you don't have to have used for a year. And the second is that if you're coming home from incarceration and you've been on methadone before, and you know that the only way you can stay sober is to be on methadone, then you can go on methadone without a current physiologic dependence. And those are good things to have exceptions for. The DEA monitors the methadone very, very closely. It's routine for us who work in methadone to be visited by the DEA. We don't find it frightening. We find it, usually, in many clinics, we find it a collegial relationship. There are drug screening policies, so you've got to get a drug screen a certain number of times a year. Usually that's once a month, and as I mentioned before, methadone is only given in clinics. Okay? So I think those are some advantages, actually, when you look at it that way, to methadone. Well, what are the side effects of methadone? There are certainly some side effects. And what we know is that opioids slow the bowel down. And so since they slow the bowel down, the large bowel, the large intestine, has a function of absorbing water. And so if stuff is moving through there more and more slowly because of the opioids, then it's going to get a lot of water removed, and it's going to become hard as a rock. So constipation is one of the side effects, and those of us who take care of patients on methadone know that that's true and can often provide some sort of a stool softener or some kind of an agent that won't cause dependency in the bowel, like lactulose. You might see certain patients who are on methadone who do not have hepatic encephalopathy on lactulose, for instance, because it doesn't cause dependence of the bowel, but it does help them to move their bowels. It can cause urinary retention, which means that it's difficult to start your stream, difficult to empty your bladder. It can cause a decrease in libido, which means a decrease in your sex drive. It can cause sedation. And initially, when you start somebody on methadone, it's not uncommon to see sedation. Now, if a patient is bent, which is why we keep people in the clinic for a while we're inducing the methadone dose, which means we're escalating the dose and starting them on methadone. And but when a person is on a stable dose of methadone, you generally don't see any sedation. You see people who can go to work, who can take care of their kids, who can drive automobiles, who can do their jobs successfully. I've taken care of people who've been sober for years with methadone, who manage companies, some of whom are millionaires and make donations to the philanthropists. I've seen people who are HIV positive on methadone who would manage their disability responsibly. There can be certain toxicity with other drugs, and so when other drugs are added to methadone, you have to be careful, and you need a doctor who's going to be cognizant of those toxicities. You can also see toxicity with alcohol, concomitant use of alcohol. It's most of the overdoses that occur in methadone clinics are not from methadone or opioids. Most of the overdoses that occur in methadone clinics are from a person who's taking methadone and uses alcohol concomitantly, or benzodiazepines, even benzodiazepines that have been prescribed. And then there's some other toxicities that you can look up as well, which include cardiac toxicities. And again, it's important for the doctor who works in the methadone clinic to know about those different side effects. Well, here's what a blocking dose is. A blocking dose blocks all of the receptors. A blocking dose takes away all of the withdrawal. And a blocking dose of methadone blocks all of the effects of opioids. So what does that mean? That means what I said before, that if a patient uses opioids on top of a blocking dose of methadone, that means that the patient is not going to feel that opioid, and that patient will not get back on a roll, and on a roll of continuous opioid use. It also means that that patient is going to feel okay. The withdrawal is going to be gone. And it is a relief to be able to give that kind of relief to the patient, as a matter of fact. It's very gratifying as a practitioner to watch that. And so when a person is on a blocking dose of methadone and they're stable, that thing down at the bottom, quality tolerance, takes over after a while, and you can't tell that a person is on the methadone at all. I have people in the clinic that I take care of right now, some of whom are on no medications for their opioid dependence, some of whom are on Naltrexone and will be going on Vivitrol, some of whom are on Buprenorphine or Suboxone, some of whom are on methadone. We've got all 4 modalities in use in the place where I work at Norris right now. And I can't tell the difference between those patients unless I look in their charts. So what is a blocking dose? Well, the average doses in this country are between 80 and 120 milligrams of methadone. That means that that's the 2 standard deviations from the mean of a bell-shaped curve. If I'm doing methadone dosing correctly, it means that I ought to have some people, most of my patients will be between 80 and 120, but I ought to have some people who require less than 80, and I ought to have some people that require more than 120. And so if I've got doses that I say are too low or too high, and I'm in a methadone clinic, I'm probably not dosing people appropriately. I probably need to titrate the dose. And what I recommend is that people titrate the dose to whatever is effective for the patient. That means we don't want too much, we don't want sedation, we don't want intoxication, because giving too much methadone, more methadone, remember, gives more and more of an effect. We don't want intoxication, and we don't want them in withdrawal. We want an adequate dose of methadone. Sometimes certain characteristics can change the dose of methadone that has been stable. If I add a medication that increases the metabolism of the methadone, I may, for HIV or for any number of other things, I may have to increase the dose of the methadone in a patient who's been stable. If a patient becomes pregnant, her dose may change, go up and down over the period of pregnancy. If I add a medication, for instance, quetiapine in a patient, I may have to decrease the dose of methadone because I may be decreasing the rate of metabolism. We've gone over some of these already, so I won't go back over all of these. I think we talked about these in the previous slide. I do want to point out, though, that when I say restrictive, that's an advantage and a disadvantage, because when you think about living in a rural area, having to travel on a 50 miles to the methadone clinic where there's only one bus that runs, that's not an advantage that the only clinic is 50 miles away from me, okay? On the other hand, restrictive can be an advantage for people who aren't yet biopsychosocially stable enough to handle a prescription for buprenorphine, or who aren't biopsychosocially stable enough or have a right brain chemistry to be able to be on no medication at all. The other thing is, we know that methadone is safe for pregnancy. We know that by the time a child is 4 years old, you cannot measure any difference between that child when he or she was born to a mother who was sober, maintained on methadone, and a mother who was did not have addiction at all. There's no developmental thing ever that occurs in a child who is born to a pregnant mother who's sober on methadone. There's no limit to the amount of tolerance that a patient can have. Remember, we mentioned that buprenorphine has a ceiling effect. So patients with really high tolerance can benefit more from methadone sometimes. Although, in practice, we've seen we didn't think originally that buprenorphine would work for people with really high tolerance. We've seen with buprenorphine that it does work for very, very many people that we didn't think it would work for. Okay, these are all myths. Methadone does not rot your teeth. It doesn't get in your bones. Yes, people can get off of it if they decide to. Withdrawal from buprenorphine is said to be different. There's a great book. It's called About Methadone and Buprenorphine. It is on drugpolicy.org. And if you can download that book for free, and it will dispel these myths. It's something you can give to your patient so that patient can see that these are all myths. It's in black and white. It's not bad for the baby. People who are on methadone should nurse their babies, as a matter of fact. People don't look sedated. They don't feel high. They don't look high. It's not bad for the liver. Here's an important one. It does not block pain. A maintenance dose of methadone does not block pain. So if you tell a patient, oh, you shouldn't have any pain, you're on methadone maintenance, that's not true. The methadone makes that patient normal. If the patient does get relief of their pain from the maintenance dose of methadone, it's usually a surprise and it's gratifying. We're grateful for that. But to assume that the methadone for a blocking dose would block the pain for a patient with chronic pain is fallacious. That is an error in thinking. And the withdrawal is not worse than heroin. It's just different. Some people say that the withdrawal is more intense than that of heroin. Some people say it's less intense. Some people say it lasts longer than the withdrawal for heroin. Some people say it doesn't. So when you're talking about withdrawal, it's like anything. You got to individualize it, and you got to take a look at what your patient experiences. Okay, let's go on with buprenorphine and naloxone. DATA 2000 changed everything. DATA 2000 is the Drug Addiction and Treatment Act of 2000. You can do a web search on that and read about it. But what it did, up until DATA 2000 happened, there was only one opioid that was approved for the treatment of opioid dependence, and that was methadone. And in order to use methadone for the treatment of opioid dependence, you had to have a specific license in the facility. So the hospital, the treatment center, the methadone program had to have a specific license that allowed them to use methadone either for maintenance or for detoxification. The only other place that methadone could be given is an emergency dose in emergency rooms, and that's without the license, but it's an emergency dose. Or it could be used for the treatment of pain. But when you're talking about without a license, but when you're talking about using an opioid for the treatment of opioid dependence, the only medication, the only opioid that was licensed to do that was approved to do that by the federal government, was methadone. DATA 2000 opened up the door so that there could be other opioids used for the treatment of opioid dependence. And the only one that was approved for that was buprenorphine under DATA 2000. So that's how DATA 2000 changed everything. And what DATA 2000 did was it took that licensing thing from the clinic and the facility and gave a waiver to an individual doctor on that doctor's DEA registration to be able to prescribe buprenorphine. So the doctor had to meet special criteria to get the waiver on his or her DEA registration, and then that doctor could do office-based opioid treatment, which you'll see it abbreviated as OBOT later in the slide presentation. Buprenorphine is made in two different kinds of products. It's made in a mono product, which is straight buprenorphine, and it's made in a combination product, which is buprenorphine and naloxone. The mono product, you'll hear this, and you'll hear this from experts, is for two things. When there is a documented allergy to naloxone and in pregnancy. Now, buprenorphine monoproduct is not yet approved for pregnancy, but there was a study done in which, it's the mother study, and you can see what that stands for, Maternal Opioid Treatment Human Experimental Research Study, was done at Jefferson Hospital in Philadelphia, Johns Hopkins in Maryland, and a couple of places in other countries. And anyway, I can't name all the institutions. I'm sorry about that. But what that study showed was the three things that are listed there. That's what the study showed. It showed that when a person who was treated with buprenorphine delivered her baby, and she was sober, in other words, only taking buprenorphine, not taking any other drugs, when the baby was born, the baby had less intense neonatal abstinence syndrome, that's NAS, less time in the neonatal intensive care unit, and less incidence of neonatal abstinence, so it occurred less frequently as well. It did not show what happens to the child as the child ages, but we haven't seen any adverse effect on kids born to mothers of who've been taking buprenorphine, who continue to nurse their baby or any other thing. So we think that when a mother cannot get to a methadone clinic, methadone is still the approved thing for pregnancy. We think that when a mother cannot get to a methadone clinic, that the next best thing to do probably is to treat her with buprenorphine, and many of us have done that without any adverse consequences at all. Okay, so let's talk about what the combination product is. The buprenorphine is what blocks the receptors. It's the partial agonist that gets on the receptor and actually blocks opioids and the effects of opioids, and blocks the withdrawal and treats the withdrawal rather from when the buprenorphine naloxone is taken. Naloxone gets into the body in some small amount, but the proportion of buprenorphine to naloxone is 4-to-1. So studies showed that when you have a proportion of buprenorphine 4-to-1 in a preparation, that you get blockade of the receptors with buprenorphine, but no appreciable effect of the naloxone that is absorbed into the body. So if you take the buprenorphine or the Suboxone under the tongue the way you're supposed to, the naloxone doesn't do anything. Now, many of you have heard of naloxone. It's what we use for opioid overdose prevention. It's what's given in the kits that the Harm Reduction Coalition, OASAS, and the Department of Health have been doing, what law enforcement agencies and firefighters have been doing, what first responders have been doing in the state of New York, thank God, to prevent death from opioids. It reverses the opioid overdose immediately, and so when naloxone is given to reverse those things, it has to be given in a certain way. It has to be given parenterally, or in some cases through the nose. So if you took Suboxone intravenously or shot it into your muscle, what would happen is the naloxone has more affinity for the receptor. It's stickier to the receptor than the buprenorphine, and it would knock off all the buprenorphine from your receptors. And since naloxone has no agonist effects. It's only an antagonist. You'd go into immediate withdrawal. And that's what it's in there for. It's to prevent diversion so that if somebody shot up Suboxone, they would have an adverse reaction. Okay, so what's buprenorphine about? Well, it's for office-based opioid treatment, which means that doctors can get that waiver and they can set up a practice in their own office. It means that outpatient programs can hire doctors who have Suboxone waivers on their DEA and give it within the outpatient programs. And we are very, very proud to say that many of our outpatient providers have done that. The doctors have stepped up to the plate and been able to do that. It's a lot less restrictive. That means that your patient can take home a prescription for Suboxone. Most of us, when somebody is getting initially treated with Suboxone, don't write more than a week of medication. And most of us wait until the patient has achieved a certain level of biopsychosocial spiritual stability before we start extending the prescriptions. The most that can be given at one time is 30 days worth of Suboxone. You can give a refill, and for people who've been stable for a long time, people do give refills. Okay? What does a doctor have to do to get the waiver? Well, the doctor can be certified by the American Society of Addiction Medicine or boarded by the American Board of Addiction Medicine. They can have a special certification in addiction psychiatry from the American Psychiatric Association, or they can take an 8-hour course and get their buprenorphine waiver that way. They have to apply to the DEA to do it, and when they do, the first thing that happens after they get the waiver from the DEA, which takes a little bit of time, they get the ability, if you look at the bottom of the slide, they get the ability to treat 30 people in their first year, and later on they can treat 100 people. That's the most that any doctor with a buprenorphine waiver can ever treat. In order to go on buprenorphine, you have to achieve a certain level of withdrawal, because buprenorphine is stickier to the receptor has more affinity to the receptor than methadone, and more affinity to the receptor than other opioids. But it's only a partial agonist. Once you get to a certain effect, you don't get any more of an effect. So if the patient requires a certain level of opioid in their body to be able to stay out of withdrawal, and the buprenorphine ceiling effect is less than that, if you give them the buprenorphine and you knock that opioid off of the receptor, they're going to go into bad withdrawal right away. So you want to wait. That's what the COWS is, the Clinical Opioid Withdrawal Scale. We're going from the bottom up here on this slide. You want to wait until they achieve a level of mild to moderate withdrawal before you give the first dose of buprenorphine, so that you don't put them into withdrawal. I'll tell you what happened to me. The very first time I gave a dose of buprenorphine was sometime in the first part of the 2000s, and I was working in Philadelphia then, and my patient was sitting in front of me. I watched what happened, and I'd never seen anything like it before in my life. The patient got immediate relief from withdrawal, and I cried, and so did he, because being able to do that for a patient, I'd never been able to do that, to relieve the suffering that way before. So a lot of us who give buprenorphine have experienced that kind of thing. DEA monitors this thing, which frightens some doctors. But again, I believe that if we're doing the right thing, it's more of a collegial relationship than it is of an adversarial. I've always found the DEA to be very, very helpful when they've monitored my practice. We are required to refer the patient to treatment. We are not required as individual doctors to make sure that the patient goes to treatment. But many of us don't want to give buprenorphine to people unless they go to treatment. So as treatment providers, if you happen to be a treatment provider, I think one of the things you can do to help your doctor in the community who's prescribing buprenorphine is maybe reach out to them and say, hey, if you want to refer people to us, we'd love to have some sort of a relationship to be able to take care of your patients, if that would be helpful to you. This is what we used to think, that people with buprenorphine would need to have less of a tolerance. It hasn't turned out to be true in the long run. We can treat people with a much higher tolerance with buprenorphine than we ever thought we would be able to do. That ceiling effect has not been as much of a deterrent to treating people with high tolerance as we thought it would be. In doing that, however, I think it's a double-edged sword, because as we treat people with higher tolerance, some of those people have more psychosocial deterioration. And when we ask them to take a prescription for buprenorphine out of our office and be responsible with it, we're asking a lot from them. So for us to be able to do that for that group of people whose psychosocial functioning is more impaired, we need, I believe that it is important for us to help the patient with the psychosocial functioning as well. Sometimes I think we need to be able to be willing to refer that patient on to a different modality of treatment if the buprenorphine isn't working, like methadone or something like that. The patient has got to have a safe environment to take the buprenorphine into. Many of us recommend that they keep it not in their medicine cabinet, but in a locked box to which they have the key somewhere else in their house where children can't get it, where people who come into their house don't see it, where it's not in danger of being stolen. If the buprenorphine is stolen, if the buprenorphine is missing, most doctors will not prescribe again. So it's important to educate the patient when they go on buprenorphine that you've got to take care of this stuff. You can't lose it on the bus. You can't leave it somewhere. You can't have it stolen. You've got to be responsible for it. Many of us think that the treatment involvement, as we talked about before, is very important. Buprenorphine itself is not toxic, but when it's combined with alcohol or it's combined with other benzodiazepines, it can result in sedation. And then there have been reports of deaths in some other countries. Okay? All right. As I mentioned before, there can be synergistic effects of buprenorphine with other medications. That means that 1 + 1 does not equal 2, but 1 + 1 equals 4 or 5. So the effects of combining some things with buprenorphine can be very, very toxic. And alcohol and benzodiazepines are two of those things. And benzodiazepines could be prescribed, they could be unprescribed. The brain can't tell whether they're prescribed or whether they're unprescribed. And the benzodiazepines, the Z drugs like Zolpidem, trade name Ambien, and Lunesta can be very dangerous as well. They work on the GABA receptor. A lot of us will do callbacks where we'll call the patient in and we'll do strip counts. And they're random. It's just a safety feature. We will do callbacks for urine drug screens to make them random so that the patient doesn't know exactly when the drug screens are going to be done. And if the patient is staying sober, one of the ways that I frame that for the patient is I explain to them that, you know what this does for you? If anybody accuses you of using drugs, we got a whole stack of drug screens here that are negative on you. It's really to your advantage to have these things. And while it's unpleasant to give a urine drug sample in front of another person, those drug samples do need to be observed so that they're not adulterated. And many of us insist that the patient needs to be involved in treatment. And for good treatment, I think what we do is we put all of this in a treatment agreement with the patient so that we're both signing off on the same thing and we both know what is going on. Now, I think the next slide that we're looking at here is something that you can look at and you can read all these different things about where stigma occur, but I feel personally when I am going to prescribe buprenorphine for a patient or methadone, I need to prepare the patient for what they're going to experience in the world when they go out there. And stigma is a real thing. Stigma occurs not only for drug addiction and opiate dependence, and if you'll look at the hierarchy within the addicted community, a lot of times people look down the most on our opioid dependent people, particularly those who are IV heroin users. You'll hear a patient come in and they'll tell you, I used heroin, but at least I never shot up. You know, and so there's stigma even within the community of other addicts. And some of that's internalized in the patient. So it's not just the addiction here. It's the stigma that exists in society about people who take these medications. And there are people who believe that the myths about methadone, that it will impair your ability to drive, that it'll impair your ability to take care of your kid. People think, there are people who will say, well, you're not sober, you're taking buprenorphine. You know what? I can't tell the difference, and I've been in this field for over 3 decades, so I'm working on my 4th. I'm old. But anyway, family members will have stigma and look down on the patient. And then there's the own internalized stigma about having to take a medication for their addiction. And I have to prepare the patient for that. I have to prepare my patient if they're going to go to 12-step meetings, if that's the decision that they make, that they may encounter stigma within the 12-step meetings as well. And if they decide to go to 12-step meetings, they're going to hear about rigorous honesty. And my patients aren't necessarily in the early stages of recovery aware of what rigorous honesty really means. And they will get confused about what's really important to share and what doesn't need to be shared in a group setting. There are some things that should be shared only one-on-one, and there's some people that, some things that are just not the group's business. But my patients will think, because of their own internalized stigma many times, that they need to share about their medication. If that's what they really believe that they need to do, then I need to prepare them that if they're going to share about that, in whatever situation, they may encounter prejudice. They may encounter people who say, well, you're not sober. And the truth of the matter is, medically, we don't see any indication that that's a valid statement at all. So if a patient decides to go on and share that in meeting, I need to prepare them that they may encounter that. And I need to prepare them for the fact that, you know what, a lot of people in a lot of meetings have a lot of different opinions about many things. I need to let them know that there is 12-step literature which tells 12-step members that they have no opinion on medications that are prescribed. So I can give the patient some literature and things like that, and I can also coach them on what honesty might mean and let them make a decision about that for themselves, so that maybe it isn't important when you go into the 12-step meeting to tell them about your high blood pressure medication. Maybe that's not the issue. Maybe the issue is that if you're not taking your high blood pressure medication as prescribed and it's bothering you and you're feeling guilty about it and worried about it, maybe that's the issue. And instead of going in and saying, I'm on Diazide or I'm on Lasix, you know, what do the AA members care about that? You can say, you know what, I've got a medical problem and I'm not taking care of it right now, and it really bothers me that I'm not taking care of it, and I'm not telling my doctor the truth, and I haven't told my sponsor, and all this other stuff, okay? Same thing with buprenorphine. It's just a medication. So I've got to be prepared to do that. I've got to be prepared to tell them that if they go on buprenorphine, there could be some opportunities for employment that may not be open to them. Whether I agree with that or not isn't the issue. It's that the employer may not let them do that. The airline industry may not let them become an airline pilot. And if that's their dream, I've got to let them know that. And then I have to help them deal with their internal stigma about being on the medications. So I think you get the point. Hopefully anybody who's a counselor out there would be prepared to deal with such things. Well, we talked about many of these things already, so I'm not going to go back into this again. It's important to remember that it has a higher affinity for the receptor. And the other one that's important is that in some people, the buprenorphine has effects not only on the mu receptor, the mu endorphin receptor, which is what most of our patients are interested in, but the delta receptor. And the delta receptor can have an antidepressant effect. When buprenorphine gets on that, can have an antidepressant effect in some people. So that's the possible psychotropic effect. We've talked about this. These are the different strengths. The 1.4 over 0.6 is a Zubsolv formulation. Buprenorphine, 8 over 2, 2 over 0.5, now comes in other strengths as well. I just want to make you aware of that. It's not so that you'll necessarily be able to recite the strengths of it. Well, if you stop buprenorphine or methadone, you're going to go into withdrawal because you've been on an opioid agonist. You're going to have an abstinence syndrome. It requires tapering doses. It should be done under medical supervision. It's important when I prescribe these things for my patient that I tell them that it is going to cause a physical dependence. It's not a thing I want to withhold from them. And it's important that if my patient wants to taper off of this, that I'm prepared to help them do so or to refer them to someone who does want to help them to do that. We know from methadone studies that you probably got to stay on the methadone for about 2 years before you begin tapering. We know that the outcomes for people who don't stay on for 2 years and try to taper aren't as good. We think, we're extrapolating, that may be true for buprenorphine as well, but we don't have those data yet for buprenorphine. Here are some other things about buprenorphine. It's a lovely thing because, like methadone, it can be given once a day, and you get out of the way early in the morning. It's the way the drug company intends it to be taken. They don't intend it to be taken in more than daily dosing. They don't intend it to be twice a day. Think about it. It's a wonderful thing. Suppose you want to go to Coney Island. Well, I don't know if you can go to Coney Island now. It's sad what happened to Staten Island and to Brooklyn. But suppose you want to go in upstate New York to Darien Lake, which is another amusement park. You don't want to have to carry your Suboxone with you. You don't want to have to risk losing it or something like that. That daily dosing is really, really, really thoughtful on the part of the drug company. The other thing that's true about the daily dosing is if we believe what we're talking about medication-supported recovery, and you know about addiction, if you have a pill that you have to take later in the day and you're an addict, you're going to be thinking about that pill all day instead of, when is my group? When do I get to see my kids? What have I got to do at my job today? What time is my doctor's appointment? All the things that we do for daily life. Once a day dosing allows you to do that. And it allows you to keep your buprenorphine at home so that you don't lose it or it doesn't get stolen. The maximum daily doses are listed there. That's controversial. I have to disclose to you that those maximum daily doses were from a study where the N was, I believe, 6. It was not a large study. So some of us are beginning to question whether that study was adequate to determine maximum daily doses. Naltrexone is not a new drug at all, honestly. It's an old drug. It's been around since the 70s, like I said, used for opioid dependence and alcoholism since the 80s, and the new kid on the block is Vivitrol. But it is a full antagonist. It has no agonistic properties at all, and contrary to what many believe, it does block cravings in 80% of people. There's a study that shows that. But it only blocks the cravings after about a 2-week period of taking it. So when a person decides to go on naltrexone, and people decide to do that for various reasons, it's important to let them know that unlike Suboxone and unlike Methadone, which can block the cravings immediately, it's going to take a little while for this to occur. And you want to provide the patient support during that time when they're not going to be experiencing relief of cravings. Maybe you, even though you prescribe Vivitrol once a month, maybe you bring them in for weekly visits. Maybe you let the counselor know, hey, check on them a little more frequently if you could, please. Vivitrol, like I said, is a depot injection. It's like Risperdal Consta or something like that, that's given monthly in a doctor's office. There is an oral form that you can see, Revia, that's given daily or every other day. That's been used in recovering physicians, recovering nurses, recovering attorneys for many, many years who have opioid dependence. And there are very good data to show that in those populations it results in long-term recovery. When you come off of naltrexone, you don't experience any withdrawal. There's no physical dependence that occurs. The doctor or the clinic does not have to have a special certification. There's no toxicity with other drugs, no need to taper it. However, in order for it to be effective, we very strongly urge concurrent treatment, as does the company that makes it. So there are reasons why a patient might decide that this is a preferable treatment for them. It has the highest affinity for the receptor. That means it'll knock off heroin, it'll knock off prescribed opioids, it'll knock off methadone, and it'll knock off buprenorphine. That means that when you put a patient on naltrexone, they need to have been free of those other medications for a period of time and need to have been in withdrawal. Methadone, some people say, or buprenorphine, some people say that the person should have been off of buprenorphine or methadone for 7 days. There are practitioners, however, I have to tell you, in New York State, who have had greater success putting people on naltrexone sooner than that. Naltrexone does all of these things that the other medications do, and in addition to that, it can also relieve the cravings for alcohol. Side effects, we don't generally see liver toxicity because liver toxicity only occurs when you give naltrexone in 5 times higher doses than normal. Okay? Important point. However, the other things, nausea, myalgia means achy muscles, a little bit of feelings like things aren't quite right. We don't see suicidality very often, and we don't see depression very often, but we see people say, I feel kind of weird. That's what they say. Those things, and decreased appetite, dizziness, those things can occur commonly. An advantage of naltrexone is, but they're temporary. An advantage of Vivitrol is that once you get that shot in there, you can't get it out. And so getting through those things, which generally resolve after 2 weeks, the patient, once they get through them, and after that 2-week period, experience the relief of the cravings, they're ready for the next injection. And it doesn't come back. Again, those side effects don't come back with the next injection. Pain at the injection site can be something. Have to be careful when you give the injection so you don't get infections. The last one down there, eosinophilic pneumonia. I've never seen that. I don't know anybody who's seen it, but basically what eosinophils are, they're a type of blood cell that gets involved in allergic reactions, and pneumonia means inflammation in the lungs. So it's an infiltration of those blood cells, those allergy blood cells into the lungs, and that can be pretty serious. So people who get naltrexone start to have shortness of breath or a cough, they need to get medical attention right away. Here's a comparison of these things. All of these things block cravings. All of these things block the effects of other opioids. However, especially with buprenorphine and naltrexone, because the tolerance is lower with those things, the risk of overdose when you discontinue those is increased. The risk of overdose can also be increased when you discontinue methadone because of the taper. But you've got to warn your patients if they decide to go off buprenorphine or Vivitrol or naltrexone that they could overdose. Okay. All of these things may block pain relief from other opioids when patients have surgery or accidents. And so you've got to get with the anesthesiologist, got to get with the surgeon, and come up with a plan for how you're going to treat the pain. That's a whole nother lecture. Sometimes we decide to discontinue the buprenorphine and the naltrexone. Sometimes people will decide to have regional blocks from the anesthesiologist. Sometimes people will decide to take non-steroidals. All of these lead to more days of abstinence, less cravings, and increased duration. So, here's some other things about this. Naltrexone and buprenorphine require you to get abstinent from opioids before you can start them. So if you've got a patient who can't get abstinent, maybe that patient would need to go into some kind of a more controlled setting, maybe inpatient treatment, maybe a detox unit. Maybe they're more appropriate for methadone, because methadone does not require abstinence before you start the methadone. You can still be taking opioids when you start the methadone. Here's some historical information. We won't go over this, but I do have to mention Marie Neiswander and Vincent Dole from New York City. Vincent was an internist. Marie was a psychoanalyst. And what they did, that people misquote all the time, they thought that methadone was treatment for opioid dependence, not just harm reduction. So the original people who used methadone used it for treatment, which is what I think we can use it for as well. Now, if all we want to do is reduce harm, and if that's all the patient wants to do, that's okay too. There's nothing wrong with harm reduction at all. But the original workers used it for treatment, and they found good results. Mary Jean Creek is another one, and who was one of the pioneers and who has spoken and who is still with us today. Naltrexone, I mentioned Richard Nixon. Jerome Taffy was his person who developed that. And then I want to make the point with all of these things historically, though, that none of these drugs are new. Buprenorphine even has been around since the 70s. All of these drugs we know a lot about. None of them are that new. They've all been around for quite a while. All right, I promised you this. All right, this is what I believe abstinence with MAT, with medication-supported recovery is. That it includes that the patient is not using any illicit intoxicants, that the patient is not drinking alcohol, there's no misuse of prescribed medications. There can be prescribed medications, for instance, buprenorphine, methadone, whatever, and the patient is not misusing those. There's no misuse of over-the-counter medications, and that all the medications the patient takes are coordinated with the prescribing physician and the addiction specialist or the treatment program. And I don't believe that abstinence from medication-assisted treatment includes being abstinent from buprenorphine, methadone, or naltrexone. People can be abstinent with while taking the medication-assisted treatment. Abstinence includes those medications being taken as prescribed. I'm not sure I said that well, but I think you get the gist. I hope so. Any questions, email me. I'll clarify that for you. Here's some other things that I think are very important right now for us to talk about. I believe coordination of care is essential. I don't believe that just because a person has been sober for 5 years that they don't sometimes need an addiction specialist in their life. And fortunately, if you're on buprenorphine or if you're on methadone, you're going to probably have an addiction specialist in your life who can coordinate care. I believe that we always talk with the patient about risk versus benefit. We talk about physical dependence on these things. When a patient, it's very important. I've heard this from addiction specialists, actually. I need to clarify this. That when I talk about being dependent physically on these medications, I am not talking about a DSM diagnosis of dependence. I am talking about that your body is physically dependent pharmacologically on them, but they are not a diagnosis of addiction. That taking these medications, that's very important. And then iStop has been a godsend to us. We have been able to look at how our patients are taking buprenorphine. I can look them up. I can see that my patients are compliant with their medication and filling it. And what I can't see is I can't see methadone on iStop. So I think what's important is that we realize that recovery occurs. And I want to draw your attention. I promised you this earlier as well. The Combat Heroin website, if you drill down in the website, you can see vignettes. You can see a segment on patients who are disclosing about their experience with medication-supported recovery and medication-assisted treatment, who will tell you that they got jobs, that they got recovery, that they got relief. And there are various tools on there that you can use. If you've got somebody who's trying to access treatment, you can call the Hope Line. And You can give the Hope Line number out to your families, out to your colleagues. You can give it out to school systems. We'd like for all of this to be out in the public. Everything on those websites is in the public domain, and you're free to request any of it. If you're in New York State, we can mail it to you, and you don't even have to pay postage, I believe. If you're out of state, I think you ought to pay the postage. So, all right. Thank you very much.
And that concludes our presentation today. Dr. Morgan, thank you very much for your time and your expertise. We appreciate it. Again, if you have any questions about Learning Thursdays, please feel free to email learningthurs@oasas.ny.gov. And don't forget to complete this very brief evaluation. Thank you and have a wonderful day.